Okay, good afternoon, everybody, and welcome to the academic meetings with the Department of Pediatric Surgery. And we wish you all well for 2021, and thank you for joining. And we have staff and doctors joining not only from East London, but we have doctors joining from the rest of the country, and also our colleagues from rest of the African countries as well. So we really feel honored with your presence. And we have two senior professors amongst us, Professor Colin Lazarus and Professor Larry Hadley. So today, our registrar, Dr. Zwandile Jula, is going to talk about a very common problem we see and deal with in pediatric surgery, which is long gap esophageal atresia. And I have invited Dr. Cornet de Vos, who is a consultant pediatric surgeon at Tygerberg Children's Hospital in Cape Town, which is affiliated to University of Stellenbosch. In addition to being a consultant pediatric surgeon, Kone has like a special qualification. She is mother to two boys. One is 7 and Ben is 3 years old. And Ben was born with complicated esophageal atresia and tracheoesophageal fistula. So I wanted Corne's experience not only as a consultant pediatric surgeon, but also as a mother of a child who has gone through many of these things which we are going to discuss. And Corne has also formed a not-for-profit organization and a support group for parents and children with this problem. And she's also doing PhD on biopsychosocial outcome of children and their families born with esophageal atresia and or tracheoesophageal fistula. So I think she is really most qualified to give her opinion on this topic. So I will now just ask Dr. Jula to present his talk. Okay, Zwandile, you can start sharing your screen.
I hope can you all see my screen?
We can see it nicely. You can start.
Okay. Good evening, everyone. I'm Dr. Jula. I'm a pediatric surgery registrar at East London in Sisulu University. And today I'm going to be talking about a long gap esophageal atresia. So with just introduction, so just esophageal atresia as a condition itself is one of the most common congenital anomalies of the esophagus, with the incidence of 1 in 4,000 live births. It affects mostly male than female with a ratio of 3:1. There are some risk factors that have been described, like a first pregnancy, maternal extreme age, exposure to hormones, as well as drugs and alcohol as well. And there's also a genetic component involved. Just to look briefly at the types of esophageal atresia that we get. On the first picture there on the right, on the left, there is a normal esophagus with a trachea. And then next to that is the most common, which is type C, which account for about 85% of all the esophageal atresia. And that is actually followed by type A, which is regarded as a pure esophageal atresia, which because it doesn't have the fistula, which actually is described in most cases as a real long gap esophageal atresia. And then the H type follows with its incidence of about 5 to 6%, and then the last two, they shed the last 4%. Okay, sorry. Okay, so esophageal atresia is associated with other anomalies, which has a mnemonic of factual, which is basically it's things that you need to look for when you have a baby with esophageal atresia. So in your investigation, you must include investigations that will show you if there is any of these defects, like your x-rays, your whole body x-ray for your vertebral anomalies. And then these babies, they will also need a pre-operative echo to check for any cardiovascular defect. And you basically look for the rest of the defects because they also play a role in the prognosis of the disease. Now, looking at the prognostic factors, so first it was first described in 1962 by Watterson, which started this classification, which basically looked at the survival of these babies based on their birth weight and whether there is a presence of severe to moderate cardiac anomaly, which basically show that the babies with higher birth weight, more than 2.5, and otherwise healthy, they have up to 100% survival rate. Now, if you look at the babies with less than 2,000 grams weight, but they're otherwise well, their survival rate also comes down just based on their weight only. But also when it's associated with a severe cardiac anomaly, it also decreases their survival rate. Now, looking at the difference between Watterson classification and Spitz classification. Spitz classification came out in 1994, which basically also look at the birth weight and whether there's a presence of the major cardiac anomaly or not. What is interesting here is that the weight had gone down by 1,000 grams compared to the one that was done in 1962, which highlights that with the improvement of neonatal ICU and the anesthetics, actually improves the outcome of the even smaller babies that before were regarded as they might not survive the operation. So just looking at now at the anatomy of the esophagus, my slide is not showing. So I just wanted to show the length of the esophagus, looking at the cervical esophagus, the thoracic esophagus, and abdominal esophagus, which is important when you're thinking of the blood supply, and because they are supplied by segmented blood supply, where your cervical is supplied mostly by your inferior thyroid artery, and your thoracic portion is supplied mostly by your bronchial and your esophageal branches straight from the aorta, whereas your abdominal part is supplied by the ascending branches of the phrenic and the left gastric arteries. So what is a long gap esophageal atresia? So there is very little consensus on what is the actual long gap. In most texts, it is described as the gap in length that is more than 3 centimeters, or in if you measure with the vertebral bodies, because 3 centimeters for 3 different weights of babies must might be something different. So they suggested the use of vertebral bodies, which is more proportional to the body of the baby. And even with that, there isn't a clear consensus, but in most texts it is described as anything more than 2 vertebral bodies. And as I've mentioned earlier, that pure esophageal atresia is regarded in most cases as a long esophageal, as a long gap esophageal atresia. So how do we measure this gap? So there are a couple of ways that are described on how this gap can be measured. And in pre-op, it can be estimated. You can be able to visualize the proximal pouch with the insertion of the reprogal tube. You will be able to see the level of the tube, and you can sort of from them think if it's going, you're going to be able to anastomose or not. But with that, you can also measure the gap intraoperatively, which is a lot more sensitive, because the actual long gap is described as when an operating surgeon is unable to do a primary anastomosis. You know, it doesn't really take into account the actual length. When the primary surgeon is unable to do it, then that might be regarded as the long gap esophageal atresia. So it can be done intraoperatively, and also it can be done by the use of the bougie that you can put on your proximal pouch. And if the baby has already had an operation, that time, in case of pure esophageal atresia, you can put an endoscopy through the gastrostomy and push it up the distal pouch. And in that way, under fluoroscopy or under the image intensifier, you can be able to measure the length. Also, the use of contrast has been described before. You can put contrast via the gastrostomy if it's already been made. And on the proximal pouch, it is not advisable to use contrast with the risk of aspiration. But if you have to use contrast, then you have to use a water-soluble contrast and try to use as minimal as possible. With all those measures in place, one can be able to estimate how far is the distance between the proximal and the distal pouch. Then going into management of this patient, it is important to highlight that this patient, they can come already in an acute setting when they are already sick, or they will also need to be transferred. So it is very important that you do your ABC management of this patient. Make sure you put up the IV line and keep them nil per mouth, and make sure you have an upper pouch suction on low suction to prevent aspiration, and start them on broad spectrum antibiotics. And you keep them sitting up in an upright position. These are all the measures to prevent aspiration. And non-indicated intubation should be avoided because it can worsen the ventilation if there is a distal fistula that's blowing air into the stomach. So looking at the basic principles of management is that it is important you have to close the fistula if it's a type where the fistula is present. you have to establish the feeding route, whether it's by primary anastomosis, or if you can't do a primary anastomosis, you have to do a feeding gastrostomy or any form of distal feeding for the baby, because the baby has to be fed during the time that you planning the final management plan. And whenever it is possible, an anastomosis must be attempted, because a native esophagus is more important than any other organ that can be used to replace the esophagus if there is a need. So you try to preserve the native esophagus as much as possible. So on the management, looking at the short gap versus the long gap, as I have mentioned before, that in the short gap is less than 2 vertebrae, and you're usually able to do a primary anastomosis. But with a long gap, 3 or more vertebral bodies, you can do it as a delayed repair, staged repair, and then you can have esophageal replacement if you failed with the use of the native esophagus. Now, looking at the techniques that are used in repairing a long gap esophageal atresia. So the use of bougies have been described before, which basically the tension on the proximal, the tension could be put on the proximal and the distal pouch, which with just the tension and the force, it facilitates the growth of the pouch. Also, magnetic bougies also have been used when the distal, where a magnet is connected on the distal pouch and another magnet on the proximal pouch. And with the magnetic force, that is meant to facilitate the growth of both pouches, which finally meet in the end an anastomose. But there's also other procedures that have been described that can be done intraoperatively. There's a spiral and a circular myotomies that were basically described also to give more length. If you cut through the myotomy, then you will be able to gain an extra length. And also, Fokker describes some extrathoracic elongation, where you basically put sutures on both ends of in distal and proximal pouch, and you, with time, basically increase the tension, and that facilitates growth as well. And then on the other side is just a esophageal replacement, where you can use colon, you can use the stomach, as well as jejunum and ileum can be used as well. So on circular myotomy were described by Leviditis, which traditionally were meant to, to be done on the proximal pouch. But there are case studies where they have reported doing myotomies on both proximal and the distal pouch as well. And also then they come with their own complication. There's a high risk of leakage. As you can imagine, cutting into the muscles of the esophagus. And on the area of the myomectomy, it's the area of weakness where you can get food impaction and then forming pseudo diverticulum as well, which will further impair the function of the esophagus. And they also have quite impaired motility as well, because of the cutting of the muscles as well, that might disrupt the nerve supply to the esophagus. And then also the flaps have been described to fix the long gap esophageal atresia. So they can either be fashioned in an anterior or posterior flap. They also come with their own disadvantages. As you can imagine, there's a long suture line, and at some point you have where three sutures line are actually meeting at one point, and this is understandable done under reasonable tension. So that type of anastomosis is at risk of having strictures or disruption and leak, as well as the blood supply is impoverished in that area because of the way that the flaps are fashioned, which also increase the risk of strictures as well. And also the way the flap is fashioned, it creates a segment of an antiperistalsis portion of the esophagus, which might also affect the function. And they say the risk of strictures are as high as up to 85% for this procedure, and about 30% will have an anastomotic leak. And then the other procedure that is described, Kimura's extrathoracic elongation, which basically describe using your proximal pouch, and it, instead of doing a traditional left-sided esophagostomy, it is fashioned in the way that it comes out anteriorly. As you can see on this picture, this baby has about 4 scars, which basically mean that this baby had about 4 thoracotomies before they could achieve anastomosis. Already you can imagine the risk of these multiple operations as well. As well as the fact that with each and every operation, you can potentially lose some length of the proximal pouch where you cutting around where you have anastomosed. But on the advantage is that it also uses a native esophagus as well. And then there is focus technique. My pictures are not projecting well. So basically focus technique is also during a thoracotomy, and you can't really anastomose the ends. It's putting stay sutures, which can be nylon or silk on both proximal and distal end, and you take them out extrathoracically with the aim of taking this baby post-op back to ICU, and you will have to basically increase the tension once or twice a day, and that will improve, will facilitate the growth and improve the length. They actually says they have been able to anastomose these babies between 8 to 15 days of this extrathoracic technique. There were also some studies that have shown the use of the combination of focal technique and Kimura, where on the proximal pouch, they use extrathoracic elongation of the esophagostomy by Kimura, and on the distal pouch, they use focus traction as well. And in that case, they were able to anastomose as well in 6 days. So these procedures, they come with massive amount of complication. The reason, which can be the reason why we have so many different procedures, it's because they have so much high rate of complication, which dysphagia is a leading complication, which occur between 50 up to 90% of the patient. and you have your gastroesophageal reflux disease as well, which accounts for about 40%, and then dysmotility about 30%. The strictures and anastomotic leak, as well as trichomalacia and refistulization as well in those who have fistulas. So these babies, they tend to spend long time in the hospital compared to the ones with a short gap esophageal atresia, and they're associated with higher mortality and morbidity. As I've mentioned, the dysphagia is the main problem as well. Also, when they start feeding, they can have some feeding intolerance, and as we mentioned earlier, that the bacterial diseases are associated with high mortality. So the management of the long gap esophageal atresia, it's still revolving, and because it's very challenging, the native esophagus is still the best way to, it still needs to be preserved. It's still the best conduit to transport food. And this patient have a lot of post-operative complications, which some of them follows them right up to adulthood. It is even shown that these babies, by the age of 5, about 50% of them, they score around less than the 25th growth percentile. Some of them, they've shown to have some growth restriction, as well as respiratory and the neurodevelopmental issues as they grow up. That's all. These are my references. Thank you.
Thank you, Zwandile. That was a nice presentation, and the very fact that there are so many operations which are described about it means that none of them is perfect, and it's quite a challenging problem. And you presented very nicely. Now I invite Dr. Corne de Vos to give her opinion, advice, and she has a presentation as well with which she will tell us her opinion. Corne, you can share your screen, please. Jandile, you need to stop sharing your screen.
Oh, sure. Yeah.
Okay, thank you, Prof. Chitnis, for inviting me to just give a different view on long gap esophageal atresia. Maybe just before I start, just would like to make one comment, and that is the use of thoracoscopic assisted or thoracoscopic pull-ups, gastric pull-ups in these children. So in Utrecht, they basically, what they're doing at the moment is if they see this child has a lung gap, they go in thoracoscopically, just tie off the fistula and put internal traction sutures on the distal esophagus and the distal and proximal esophagus, and they don't wait long. They only wait about 3 days. They don't do other internal traction things, and then they go and do a gastric pull-up. So there's no gastrostomy or anything like that. And apparently they haven't published their results yet. They're still busy with the trial, but it seems like they have very good results, and that might be something that we need to consider in these long gaps. So Prof. Chitnis just asked me to give a little bit of a different view on a long gap esophageal atresia. And this is sort of the first time I've really shared some of my personal experiences, but I think it is important for us as surgeons to try and remember that there's a lot that the textbook can teach us, but there's some other things that we just need to keep in mind when it comes to these children. Can I ask, Prof. Chitnis, can you hear me well?
Yes, we can hear you perfect.
Okay,
Yeah.
thank you.
Okay.
So I started as a pediatric surgeon as anyone else, and I think when it comes to esophageal atresia, this is the one operation that sort of defines us as surgeons, or that's the way all of us would feel. And I think this a quote by Dr. Willis Potts is sort of explains it all. So it's the only pediatric surgical operation that really is so delicate and precise and is a pure form of art. So we all want to be part of esophageal atresia repair. And whenever they come in, and it's so nice when they do well, and if they don't do well, then, you know, we'll learn from our mistakes, but we'll try again. Um, so this is the way we always been, and I've also been part of it. But then in 2017, I got to learn a little bit about what I call the other side of the wrong side of the bed. So when your baby is born with esophageal atresia, all of a sudden, there is all the doctors that start running around all around you, and all the information is being, shared to the parents without them really always understanding what's going on. And I got to experience this. So all these people are telling you this is going to happen to your baby, and it's really a whole different mindset. And I think as pediatric surgeons, we really need to think about what the parents are also feeling and the emotional whirlpool, and just stop a minute, not run around and plan theater and all of that a bit. So when I think, or when I heard Bernard long gap esophageal atresia, these are the things that I was thinking about. And I think all of us should also really just consider this. So long gap usually means long hospital stay, that the previous speaker also mentioned. It's got high morbidity. And with all of this comes multiple surgeries, and it's really emotional roller coaster. One day your baby is well on the ventilator, just about to be extubated. The next day, there's severe reflux and they have to re-intubate him. So there's the whole emotional roller coaster, and we really need to try and communicate and be there for the parents, so that we can help them through all of this. Some of the challenges of a long gap is that we need to teach parents how to use feeding tubes. I don't know how many of you have tried, but it's not as easy to actually use the feeding tube and not only insert it into the stomach. So it's a daunting task, and that is something that, you know, the parents needs to get used to and needs to be comfortable using. Also, some children might have esophagostomies. Again, that comes with its own challenges. Having a little hole in the neck can be quite frightening. And then, if you're lucky enough that you can go home before the second surgery, again, that comes with its own challenges. What happens if your child aspirates? What must you do? Must we teach parents CPR? What happens if the Mickey comes out in the middle of the night? So those are just practical things that I don't think we as surgeons always think about. And then when the second surgery comes and the repair is done, after esophageal replacement surgery, whatever it is done, that comes with a whole set of challenges that we don't always think about. So yes, now you might not have an esophagostomy anymore, but now you've got a nasogastric or a nasojejunal tube, or your baby don't want to suck on the bottle and you need to teach parents how to do that, or there's severe oral aversion the longer we wait. So we need to explain and be there for him through all the different steps. And in the end, you'll get a little baby like Ben there at the bottom with his face full of food, but you know, okay, you've done it. After that stage, obviously, you think all is done, but then the next step comes with the dilatations and the reflux and all those things. So we need to make sure that we understand the whole road, a long journey when it comes to a long gap esophageal atresia. these are just a few things I think the textbook don't teach us. So they teach us nice the theory and all the different types of repairs, but they don't teach us these things. The first, very most important thing is that this is a team effort. It's not just surgeons that's involved in this whole thing. You need to have a good relationship with the neonatologist or the pediatrician, depending if it's the first or the second surgery. Those that look after the children, they need to understand what's happening during surgery. They need to know about the anatomy. We need to have a good relationship with the speech therapist, the dietitian. These children don't grow and follow the normal a normal growth chart. So you need to have a dietitian that understands that and not always gets panicky if the child is not on the third centile. You need the pulmonologist and that needs to come and scope the child. So it's really, really a team effort. And what I'm trying to do as part of my PhD to look at this and to see, can't we just establish a good team that knows these patients so that you don't have to try and explain this every time to a different person. And then other things that I think it's important for all toughs, not necessarily just for long gaps, but before you go and do the first surgery, we run around, we get consent, but we forget that for a long time, these parents won't be able to hold their babies. And this is extremely important for the bonding process and also just for the emotional well-being of the parents. So before you put in all the tubes and go to theater, most babies aren't ventilated. Try and get the parents just to hold their babies, because for a long time they won't be able to do that. And then this is very important, is to try and explain to them several times the procedure, all the different outcomes, and what they can expect from the surgery. These moms, like with all moms, neonatal surgery moms, just had a baby. She's very emotional. Now you rush the baby off to theater. Most of them won't listen the first time you talk to them. So just try and do that. And then it's good to either have a good sister in ICU or a counselor. In government, we're lucky enough to have social workers to just help these parents in the rotate. Someone that they won't feel silly if they just go and complain about their day. They need someone to know that there's someone that's there for them. And then, like I said, it's important to explain the rotate. Specific to long gap, I think a lot of us are very hesitant when it comes to esophagostomy. But from personal experience, I think the advantage is, if you know you're not going to get the two ends together within a month or two, instead of keeping the baby in hospital indefinitely for 6 months or so and waiting to go and do a replacement, it is a good option. And then the parents can at least go home. This is obviously not for every child, but it's just something to think about. And then, like I said, it's really important to get the parents confident with the feeding tubes before they go home. You need to let them take out the Mickey and put it back in so that they don't freak out if that happens at home. You need to tell them it's okay that it leaks. They really need to have good training, and there is a lot of nurses and reps that will go to parents and go to their homes and teach them. But I think that's a thing. And then something else that we can't always do in the government system because of lack of theatre time and ICU and of those things, but something to consider is to try and do the esophageal replacement if you can't do definitive surgery early on. The benefit is that most of the mums is still on maternity leave, so they don't need to take extra leave. But it also helps when it comes to feeding. The longer you wait, the longer it takes for the child to start feeding, the worse the oral aversion is. So these are just a few practical points that you just need to consider every time you have a child with a long gap esophageal atresia. And then I think it's also important to remember that this is not only happening to the patient or the baby, but it's also happening to the whole family. So you need to have systems in place to counsel them and to know that they're there for them. there's a lot of studies that's coming out that show that parents of children who undergo neonatal surgery has got a lot of PTSD and anxiety, especially later in life when this whole ordeal is done. And that is something I think we need to try and pick up and address early on and try and prevent this. Also for patients, especially the older they get, I think a lot of us knows the children that goes to hospital every month for a dilatation. The more dilatations or the more hospital visits they go, the worse the anxiety gets. So try and do it a little bit better. And one of the things that some of the one of the support groups is doing is giving hospital teddies to these children, and whatever happens to the child happens to the teddy, and they sort of have a bonding ritual and they get badges. So there's just small little things to try and make the anxiety worse for them. And then I think it's very important for those that have brothers or sisters, it's important to try and involve them sometimes into this whole process. Let them come and visit. Obviously, COVID is making that a little bit difficult, but just try and get them involved, because whenever baby is going to go home, he or she will get more attention. And I think this might just help a little bit in that. And then, as Prof. Titmus has mentioned, because of all of this, we have started a non-profit support organization and support group. And this is for everyone in South Africa that has either a child that's being born with esophageal atresia or that are themselves a patient. We've got a few, we've got about 4 adult TOFs in the group, and then we are also privileged to have some members from across the African continent, from Kenya and Namibia and Tanzania. So please, for all your patients that you operate, you can give them our contact information, and they can get into contact us. And what this is good at is that it's not run by me or by doctors, it's all run by parents. And they've got a WhatsApp group where they can basically share their emotional stories with each other, and in that way help each other to say, don't worry, it will get better, or we've been where you are. And it connects people across South Africa, private and public platforms, from whatever kind hospital you were. We even got members from Komatipoort. So it's really nice for them. And then they've got all these little tricks of trade that we as surgeons don't know. So they have nice practical advice that they give to the patients. We also have a website where there's some inspirational stories with information about the disease. And then these are just some of the resources that we try and give to our members. Like I mentioned, a teddy. So if a child has got a Mickey, they'll put a Mickey in. If a child has a scar, it will have a scar mimicking the child. And then there's other products as well. Thank you very much.
Connie, thank you very much. That was really excellent, and actually that was the reason why I wanted you to be the invited guest for this talk, because as a mother of the child and as a family with such a child, you have given all of us a different perspective for us to think about every time we have such a child. And I think all of us must actually remember that there is this support group which is not restricted to South Africa only, and they must try and get patients join the group so that they can get support from each other. So Corne, thank you. We've got lots of people we can take their opinion and advice from. I'll just start with Professor Hadley, who has joined us today. So Prof. Hadley, your
Hi, Milan.
Hi, your comments, your opinion about this very challenging topic and problem.
Yeah, and I congratulate Dr. Jula for a nice documenting all the various operations that have been tried and that don't work in sorting out the esophagus. But I must say, I was alarmed by one of his x-rays showing contrast medium in the upper pouch. And I think whatever you put in the upper pouch is going to end up in the lungs. And the only contrast medium safe in the lungs is air. So I would suggest that if you need to fill the upper pouch with something so that you can see it, fill it up with air. I was also surprised to still hear the mantra that the native esophagus must be preserved. Many of the difficulties we run into, and we end up with these esophageal cripples, is because we haven't been bold enough to say, this esophagus is never going to work properly, and go for a primary esophageal pull through, whatever you're going to do, whether be it colonic, be it gastric, be it or anything else. And I think you've also got to cut your suit according to your cloth. In our practice up here, it was not safe to have a child with an intact upper pouch. There was absolutely no way that we could maintain constant low pressure suction. There was no way, because our nursing staff were few in number and grossly overworked, there was no way we could rely upon them to keep that upper pouch dry. So whenever we were waiting, for whatever reason, they all had an esophagostomy. And to answer Cornefos's point about food aversion, we used to feed them, and you would put the milk in the mouth and 2 seconds later it would appear on the neck. We didn't mind the mess, but it did keep the baby sucking, and it taught them how to do it. And so I think this lessened our problems with introducing feeds once we'd got an esophageal replacement in place. So yeah, I mean, it's a very taxing topic. I once spent a week with John Foker in not doing any work. We were cruising around Cuba, calling it various. He's a delightful man. And he has argued long and often with Arnie Koran, who's well known to the more senior pediatric surgeons in South Africa. But he has always maintained that stretching the esophagus, putting tension on the esophagus, stimulates growth. You're not just stretching the esophagus, you're causing the esophagus to grow. And that is the object of the exercise. And I've done all of the techniques that were mentioned by Dr. Jula, and I'm absolutely confident that if one of them worked, it would be being used by everybody. But I think the safest way when you're in a hole is to put in a gastrostomy, esophagostomy, and plan an interposition of some sort. That's my view. Nothing if not controversial.
No, thank you, Prof. That's very useful. Thank you very much. And now I invite Professor Colin Lazarus. He has vast experience of managing these babies in state and private, and he has done many esophageal replacements, and many of them in the early infancy as well. So, Colin.
Yes, Milind, thank you, and congratulations to the speakers thus far. And Larry, thank you for your contribution. I was wondering just what point I would like to make. And I thought that perhaps honesty was important. Don't always think that, but this is probably one of those times when it would be appropriate to say that. You see, the mantra that of us needing to preserve the native esophagus and that the esophagus is best is repeated often. What I also hear repeated often is the capacity of some of my colleagues to anastomose ends of esophaguses together, which I know when I try even half of the distance, I'm not capable of getting a proper anastomosis. And so when there are these long gaps, I bail out very easily and very early in order to plan an esophageal replacement. And so that is not without complications. If for example, there's some tracheomalacia, and I'm going to bring up a stomach up there, it is in fact going to compromise the airway as well. So it's not as if it is without complications, but patients who have the esophagus brought together under unacceptable tension often leak And with that, in our setting, patients die. I'm not talking about tiny leak, I'm talking about major leaks. Patients die. And so I think what we've been hearing from the guest speakers is that we should think twice before we accept the mantra that I can always get it together. Well, I certainly can't. So thank you for the speakers, and I look forward to hearing experience from elsewhere in Africa right now. That would be good. Thank you.
Thank you, Colin. Thank you very much. I see Dr. Marian Arnold, consultant pediatric surgeon from Red Cross, has also joined us. So, Marian, your thoughts, your views about this topic? Marian, can you hear me?
Hi, Milind.
Yes.
I think it's a complex disease, and I think one long gap is not the same as another long gap. So I think you really do need to individualize according to the patient and according to the patient's circumstance as well. I think Corné pointed out, the impact on the family of a very long hospitalization and the long-term impact on the child in terms of, long-term speech and feeding problems. I think, we need to consider in every individual case, not just the technique, how we're going to get the ends together, but the timing of those surgeries, and our technique might depend, for a patient with the same sort of pathology, it might vary from one patient to another depending on things like social circumstances and things like that. So I do think, you have to always look at the opportunity cost for everything.
Okay, Marian, thank you. Now I'll just invite Dr. Majola, who is our consultant pediatric surgeon. Dr. Majola?
Evening, everyone. Thanks, Prof. I don't really have any further comments to comment about because all the other speakers have mentioned what I had wanted to mention. But as everyone has said, the experience plays a key role in trying to fix the pathology per se. And the less skilled and the less numbers of these operations that we do, I think the best sort of management for these kids on our sort of experience level is to offer them an sort of esophageostomy and a gastrostomy and plan for a conduit, which is by far will be, although it's not ideal, but I think it will give the patient a better outcome than trying to bring the two ends together, and which will cause more problems.
Thank you, Kuleko. I think you have honestly told us the facts, and rather than what all seniors are also telling us, and what we have also followed, is rather not make it an ego issue, but do what is the safe thing and what the system can cope, what our nurses, doctors, the parents can cope, and that is probably the best for that child. I'll now invite Dr. Manikchand, Yashoda Manikchand, our another consultant. Do you have any comments?
Hi, everyone. No, I don't have anything to add. I just want to thank Corné for her sharing her personal experience. That was really valuable. So thanks to Corné, and thank you to all the contributors.
Yes.
I tend to agree with all the sentiments.
Thank you, Yashoda. Selo, Dr. Selo Machaya is our consultant pediatric surgeon. Anything, Selo?
Nothing new, Prof. Thanks again. But I think just reflecting on what everyone is saying, I think you should do what you know and are capable of doing comfortably, and not try to experiment. You can sit there and try to do these myotomies and do the levaditis, do the Charlie, and fail. And remember that you're dealing with a patient, you're not dealing with a guinea pig here. So it's always best to do something that you're comfortable with, that you have adequate skill and experience with. before trying these procedures. Even if you don't have experience, definitely have someone with experience at least guiding you throughout the process so that you can have a good outcome, because no one wants to have a bad outcome from any procedure that you have. So I think having a good experience with any kind of lengthening procedure would ultimately help. But being able to select your patient adequately is very, very important, in that you assess the patient, think, okay, will this patient withstand multiple operations, or is the best thing for this patient just to actually divert the esophagus and bring out and put in a feeding tube? So I think experience plays a huge role, which I think we're all gaining as time goes on and trying to make the best decision for the patient. Yeah. Thanks, Prof.
Thank you, Selo. I think that's what we are also doing. We help each other and we try and get the maximum experience, especially when we do gastric pull-ups and procedures like that. So thank you. I see there are colleagues from Africa. So if any one of them wants to make any special comment, any problems they encounter, anybody can just unmute yourself and just make a comment. Anybody would like to make a comment? Okay, I don't see any hands raised. I don't see any people unmuting themselves. So thank you very much. This was excellent. Our aim is to have a brief presentation followed by advice by the invited guest and comments by the other consultants and senior people who attend the meeting. And I think that has been fulfilled. And it's about 58 minutes. We are finishing the meeting, which is ideal. So thank you very much to Zwandile for presentation, Corne for being present and sharing her personal experience and insights, Prof. Hadley, Prof. Lazarus, Marian, and all our colleagues from rest of Africa. Thank you very much. Next week, it will be meeting for our department, which will be morbidity and mortality meeting. And the first Tuesday of February, the meeting will be open to everybody and it will be about TB and pediatric surgeon. So we hope to see the rest of you in 2 weeks' time. Thank you very much. Have a good evening.
Thank you, Milan.
Cornet, thank you very much.
Thank you, Prof.
Okay, bye-bye.
Bye.